Okay, good morning, good afternoon, good evening. Welcome to day 2 of the MCBK Global Conference 2023. I'm Philip Scott, I'm co-chair of the conference. I'm the Programme Director at the University of Wales Trinity St David and Professor of Digital Health and Care, working along with Chuck, who will introduce himself now.
Yes, hi everyone. I'm Chuck Friedman. I'm the chair of the Learning Health Sciences Department at the University of Michigan in the USA.
Thank you, Chuck. So first of all, we'd like to start with thanks again to our programme committee, to the presenters, all of our meeting staff for their help in making this meeting possible and for arranging the great programme that we have. So as we say, this is the second day of our 2-day event with sessions to accommodate our global participants at different timings. So the session overall is about 4 hours, which is 10 till 2 in Australia. Have I got the right ones here? This feels like the evening timings. But let's flip over to the slides rather than the text here. So I think that this slide has the correct timing. So here we are at 9 a.m. in US Eastern Time, 6 o'clock on the West Coast, 10 a.m. in South America, 2 p.m. in the UK, and so on from there. So we've had over 500 people registered for the meeting, joining at different times of the day, altogether representing more than 40 nations. So here we are on day 2 of the meeting. Yesterday we held the 2 sessions for the 2 main kind of blocks of time zones. And here we are now, day 2, session 1 on the 4th of October, and we look forward to this half-day programme. So we do have one important change to mention to the programme that was originally published. Because of the technical difficulties we had yesterday with the streaming of Mark Mewson and Karen's session, we've now shortened the regional chapter session. So now we have, the programme remains the same up until the keynotes at 11 to 11:45. So that's then followed at 11:45 by the large language model discussion between Mark Mewson and Karen Vespoor. And we still have the global chapters session, but that's now reduced to run from 12:05 to 12:45, and then followed by the meeting summary and conclusion as scheduled. So please note that change for the large language model discussion. So technical information, if you weren't here yesterday. So during the plenary talks, please submit questions as soon as you think of them as the speakers are talking. If you're not sure what they mean, or if you disagree with what they say, or you'd like to expand on it or clarify it in some way, please pose those questions in the Q&A option of the IBM platform. So reminder again, it's the IBM platform for the plenary sessions, and we'll be going out into Zoom rooms for the parallel sessions, as that helps us to have more interactive discussions. And if you're looking for the links to get to the right Zoom rooms, they're all found from the IBM video player. There's a link to the document, and the document has the URLs that will take you to the respective Zoom rooms that you want to join. And then the recordings, as they become available, they'll also be found on the IBM video player. There's a video tab that has links to all the recordings as they are released. So that brings us to the beginning of our main programme for today. And so let me hand over now to Chuck to introduce our first main speaker.
Thank you, Philip. It's really a pleasure to introduce Professor Deepak Kalra, who is president of the European Institute for Innovation Through Health Data. He's a professor of health informatics and formerly a London general practitioner. He plays a leading international role in electronic health record research and development, including the reuse of EHRs for research. He's led the development of ISO standards for EHR interoperability, personal health records, and data protection. Among his many projects, he's engaged in scaling up the quality, interoperability, and reuse of health data for research, including inputs to the European health data space. He also pursues scaling up of the collection and use of health outcomes toward more value-based care and initiatives to explain the value of clinical research to the public. Deepak's work is extremely pertinent to what we are trying to achieve in MCBK, and with an eye toward MCBK as a global entity, it's very, very useful and will be enormously beneficial to us to hear his perspectives on the European health data space. So now we will turn things over to Deepak. Deepak, welcome and thank you for being here so much.
Chuck, thank you so much for that warm introduction and also for your kind invitation to address this very auspicious event of the year. MCBK is absolutely mission critical to the future of healthcare, to the benefit of patients, and so we all must do the very best to help it to thrive. So thank you for inviting me. I think I should click on, so I will start by telling you that the topic that I'm going to speak about today is really a rather exciting adventure almost. It's a mission, it's an initiative, but I think adventure feels like more the spirit, called the European Health Database. And I hope that you will feel by the time I've finished that this is something really exciting that's going to bring benefits undoubtedly in Europe, but I think will echo planet-wide and may inspire others across the planet. Let me start, though, with an example. And an example is heart failure, just picking it for the moment. Heart failure is something that is massively prevalent, results in quite a significant burden to health systems, as well as a burden to society. And we must therefore do the best we can to try to improve the quality of care for patients with heart failure. This diagram is taken from the US with US data from ARC that some of you will know. I couldn't get exactly matching data from Europe, but colleagues at the European Heart Network have indicated that the cost in Europe for totality of care, not only hospital care, is around 29 billion. The key thing is it's a big impact on healthcare. And are we spending that money wisely? So this slide, which is now a few years old, but I think still has the right message, which is that there are a series of orange bars on 3 charts on this slide, which are not the same length. They represent information about the variation in the risk of death during the first heart failure admission, 12-week mortality after admission, and readmission rates. And what you can see from this is that countries are not achieving the same quality of care and the same health outcomes. And the countries vary slightly on the 3 charts in the order. So countries are getting some things more right, some things less right. The key thing that matters here is that as a health system globally, we are not yet strong in understanding what are the elements of a care pathway, what are the interventions that really maximize outcomes. But we have heaps of data from which we can learn, if only we choose to learn, and the opportunity to apply that learning back into cycles of quality improvement. Another example, at the very micro scale, is a single hospital, the Liverpool Heart and Chest Hospital in the UK, which is looking after patients awaiting cardiac surgery. So what they have started to do is to issue patients with equipment to use at home to record their blood pressure, oxygen, and diabetes, if they have diabetes monitoring, and capture some key symptoms. Specialist nurses have a dashboard that allows them to review the progress and the state of each patient. If there's an escalation, then they can contact the patient directly, maybe make a change in treatment, if needed, even bring this patient in for surgery more urgently than they were otherwise listed for. And for patients who don't have a phone call, who don't get any contact, there's a huge amount of reassurance that whilst I'm waiting for my heart operation, I'm not getting any worse, which is tremendously valuable. Now, what they've found already is that they can reduce emergency hospital admissions, which are hugely disruptive and distressing to people on a humanistic level and very expensive for the health system. Furthermore, in-depth economic evaluations are ongoing. And I'm picking this an example because many of you will have examples of your own or colleagues that you know that can show the same thing. Our main challenge, really, I think, in this game is how do we go forward from here? I'd like to mention one more step in the process, which is a European project currently in the middle that is looking to try to tackle advanced heart failure, again with patients mostly at home through digital tools, giving patients an app that allows them to have some autonomy over the monitoring and the actions that they take with their heart failure care, clinical decision support, and also introducing innovative artificial intelligence to try and anticipate deteriorations of each patient. So the patients have a very simple app that allows them to capture some immediately daily readings. They have charts that show them their progress, and they have a care plan with goals that helps them to understand where their contribution to care is. And then the clinicians have a dashboard that gives them progress, but also it feeds into this dashboard information extracted from the electronic health record. So although this is to some extent a standalone tool, there's no duplication of data entry, and the results can be fed back into the EHR. Again, what I'm showing you here is about advancing digital tools, in particular the ability to learn from data to generate machine learning solutions that we hope in this project will help to enable patients to anticipate early if they're deteriorating, so interventions can be applied early, hopefully hospitalization avoided, quality of life improved. And I'm sure, again, you may be saying to yourself in the audience, yes, we've got lots of examples of this, and I think that's fantastic. But for most of healthcare, they are just examples. And the problem we have is how do we scale up from here to really accelerate the deployment and wide-scale use of these innovations? And how do we accelerate the learning so that the MCBK magic of developing ways of computing and generating knowledge from data can accelerate right across the health spectrum and deliver value? Now, you all should know this slide. I bet blindfolded you could all have drawn it, because this is one of Chuck's seminal slides that reminds us of the cycle of learning. But it's a cycle of learning and doing. Yes, I find it easier to speak about this from the bottom. You capture what's happening in practice as data. You assemble it, you analyze it, you look at the results, and then the red part comes in. And this is, to me, the exciting part. How am I going to be different? What am I going to do differently in order to change the way care is delivered, the outcomes for patients? And of course, that yields new data that allows you to refine and keep improving. And bottom right, formation of a learning community. This should not be a solo sport. Let's do it together. That's really important. And we need to learn from data right across the spectrum, from care to research. Near to the patient, there are a whole series of bullet points. I won't speak to them. You can read them. You know them anyway. These are the things that really need to be dealt with through innovative technologies and smart digital solutions near to the patient. But then at population level, we have a lot of learning to do. We discovered through COVID how slow we were to develop intelligence and share it at scale globally. We need smarter public health and population health intelligence systems in the future. And of course, we've got to accelerate research and innovation to develop better drugs, better vaccines, digital solutions, AI, and so on. An example of why this matters, why do we need to learn from data at scale? is a project called Conception I'm involved in, and it's looking to establish better evidence for the safety of medicines in pregnancy. And the situation here is very simple. You can't ethically do randomized controlled trials in pregnant women. You can't take the risk, and they won't take the risk. But pregnant women have health conditions, they take medicines, and they experience the outcome of those medicines. So we have the ability to learn about the safety of medicines without imposing anything on anyone, but by learning from what's happening in real life. So this is a pipeline. I'm not going to talk to the detail on this slide. What I just want you to see is that this is a pipeline of taking data routinely captured, messy and clean together, cataloging it, cleaning it, doing data quality improvements, signal detection, and eventually developing results that can be disseminated by the project and hopefully by sustainable efforts to enable women and their caregivers to make wiser decisions in the future about how their treatment should or should not be changed in the light of their intention to get pregnant. This is just one example of so many, and the reason I wanted to speak to you today is to say that certainly in Europe, this is an exciting landscape already. There are many initiatives. I've just got here a splash screen with a few logos. These are examples of initiatives, some of them within country like France or Germany, others across border operating at a pan-European level on certain kinds of data like life sciences data. For example, look at rare diseases, looking to try to accelerate that learning at scale. Mostly what they're doing is using a federated architecture. That is, rather than sending large volumes of data between places, they are instead running distributed queries to try to minimize the data protection issues, but also to make it realistic to be able to run these queries at scale and get near to real-time insights from the data. But when I said exciting, let me get to the real excitement. The proposal from the European Commission for a European health data space. And this is a multi-billion investment plan to interconnect country-level and cross-country level infrastructures like the ones I showed on the previous slide into one gigantic cooperation environment for data. And it's a funded ecosystem, including a governance ecosystem, to say laying down the ground rules for when and how data may be used and safeguarded. I'll get into that a little bit. And it's part of a bigger landscape. In fact, there is a European data strategy, which is not only health related, but it's aiming to make Europe a globally competitive place for data and for the development of innovations around data. And the European health data space is only one of multiple data spaces the Commission is launching. And you can see that there are sectors like agriculture, energy, transport, and so on that are part of this process. We are very surprised, I would have to say, maybe I'm the one that's surprised, that health has been chosen to be the first data space of all of them. We are, I'm afraid, used as a health sector to being the last one in line when it comes to opportunities that are cross-sectoral. So we're delighted to be the first. And I think what you will find is if you encounter people in Europe who are in the health data ecosystem and the MCBK ecosystem, we are all really looking forward to learning about how this is going to take shape and what it's going to deliver to everyone. And of course, how we can contribute to this. We need to be co-players in making this a success. What's it all about? The first thing to tell you is that the EHDS, if you don't mind, I'll now call it that from now on to save my breath, the European Health Data Space, EHDS, has two levels of activity. And I've chosen green and blue to depict those: primary use and secondary use. So primary use is all about the patient level information to support the individual when they travel across Europe. And the first of the requirements in the regulation is, in order for data to travel around the European superhighway for patient-level data, is the data has to be quality checked by electronic health record systems, and it has to be interoperable according to a European electronic health record exchange format that I'll tell you about a bit later. So there's a requirement on EHR systems. Patients must have access to their data. It must be consolidated. They can't be told by a country, yes, you can have all your data. It's in these 26 different healthcare providers, go hunting. Then each country is required to have a method for consolidating the data for each patient. It must be free. They must be able to write in it. Of course, their contributions can be clearly labeled as such, and they have the right to portability to shift that data from A to B if they have any need to change provider. It is important to recognize that the plans for the European health data space hinge upon the ability for countries to interconnect with each other. So each country has to establish a contact point, and the EHR systems have to be, at the moment, self-certified. And there is a plan for the voluntary self-certification of health and wellness apps. Finally, there is a plan for increasing the level of control by patients about who can access their data, especially across borders. Now I move to the reuse of data at scale, data sets that are going to be made available through the blue in my color scheme, European superhighway. These data sets have got to be quality labeled. And there is a project about to start in which we'll be involved, which will be defining that quality label. Fair metadata must be provided, and there will be catalogs at country level and European level to allow for searching for data sets. The EHDS is absolutely clear that the data for secondary use must be for a list of permitted purposes and cannot be used for a second list of prohibited purposes. And those lists are vital for public confidence. The permitted purposes include things you'd expect, like research, like education, like public health. Prohibited purposes include, for example, development of things that advance tobacco, things that might prejudice people's insurance, and so on, unethical things. The data is normally to be anonymized, and people must not be charged exorbitant fees for the data. They must be proportionate to the cost. There are bodies that will be established to enable the data to be accessed. They will establish safe havens and so on. And there is a requirement for the bodies at each country level that make data sets available to be transparent to the public about what data sets they've made available and to whom and to why. So this is why it's a really big bang. Now, I wanted to say something also about the exchange format. The European Electronic Health Record Exchange format is not today a comprehensive electronic health record format. It is a patient summary. Today it's anchored on the European patient summary, but I'm sure many of you know that there's been huge work to advance an international patient summary, and it will migrate towards that because the two are very similar. Electronic prescriptions, dispensing of prescriptions, those various kinds of report are part of the EHDS regulation, and they are the European Electronic Health Record Exchange format, Mark 1. There are already plans afoot for Mark 2 that will be more extensive, but let's walk before we can run. The plan is to get this in and get this deployed and operating at scale. So it's part of the regulation, and it will be implemented through something called My Health at EU, which is the patient-level superhighway I described to you. Now, although it is a limited electronic health record, we should bear in mind that the international patient summary is pretty rich. And when we're thinking about the learning health system, and if I could be frank, how disappointingly little learning takes place today by most healthcare providers from data they already have in their fingertips. The ability for us to learn across all of these data items you can see on screen on multi-million patients is already a phenomenal advance, let alone then extending that gradually into the Mark II version of the summary or the exchange format in due course that will add data sets to it. I mentioned to you that there is self-certification of EHR systems, and some of those include the requirement for interoperability features, that is, of course, the exchange format, that personal health data must be exchangeable between EHR systems, breaking the logjam we have today of proprietary lock-in. Also, that EHR systems of the future must better enable the entry of structured data by clinicians in machine-readable formats. And that is that there must be investment in user interfaces, coding support, so that clinicians are guided and eased into improving the computability of the data they collect. And I won't go into the other details on this slide. This is just for your information, but just to say the details of what that certification program will contain are awaited. But there are two very valuable ISO standards dealing with electronic health records and electronic health record systems that we hope that they will take on board, and organizations like mine will lobby for aligning with international standards wherever possible. I mentioned also health and wellness apps, and I think it's important to know that if you look today, the use of these apps, when they occur in the hands of clinicians who know what they're doing, healthcare providers who know what they're doing, wise choices can be made, patients can be given apps, but it's very difficult to scale to that. It's largely enthusiasts who've taken the trouble to know which are the good apps they can recommend to their patients. So we're excited about another initiative in Europe, which is to try to establish a pan-European scheme for the quality labeling of health and wellness apps. This also draws on another ISO specification, 82304 Part 2, which is a health and wellness apps specification. And we would like to see the possibility of everybody who wants to look at an app having something like what we have in Europe today, which is an energy label, a kind of, as you can see, a color chart that tells you the strengths and weaknesses of each app under several categories that matter to patients. Things like the evidence in favor of its effectiveness, its safety, its data protection, its robustness. And of course, behind all of these colors is the detailed sets of criteria by which they were assessed. So we see this as another complementary area to support the EHDS. Now, I'm going to deviate for a moment from the European health data space to talk about artificial intelligence, if I may, which fits in, though it's not an entirely random deviation from in my talk. Europe has also passed, I think globally, the first most stringent regulation on artificial intelligence. It doesn't only apply to health. It stratifies AI solutions in a risk hierarchy, and the regulation actually explicitly states, and I think I might read it out if you don't mind, in the health sector, where the stakes for life and health are particularly high, increasingly sophisticated diagnostic systems and systems supporting human decisions should be reliable and accurate. The EHDS will facilitate non-discriminatory access to health data and the training of AI algorithms on those data sets in a privacy-preserving, secure, timely, transparent, and trustworthy manner with an appropriate institutional governance. Well, that's a bold promise that the EHDS will enable non-discriminatory access. There are a number of obligations that AI has to fulfill, and high risk where we are expecting most health uses of AI to be classified is that you've got to perform a risk assessment and to have mitigations. You've got to use high quality data sets to feed the system. You've got to log your activities and have traceability of results. You've got to provide documentation to help people to know how and when they should use your AI solution. And there must be human oversight measures in place. Now, there's a lot of work currently internationally going on what should be good practice and how you enable AI to be understood by a potential end user, by a potential purchaser or decision maker to say, I will use AI in my solution space. Among the list of bullets on the left, and I've just got an example of publication on the right, but there are many more, a critical success factor here is that the training data is of good quality and that you have characterized appropriately who is in your training population, because that represents the potential for bias in the data that you've got. So data quality comes up. And it's important to recognize that data quality is surfacing in recent years as an important topic, having been for many years before this an academic activity. So there's lots of publications, but we're only now starting to see more and more news stories about where quality issues in the data have led to human error, to institutional error, and to serious mistakes. So we are very keen as an institute, and I think we're very keen to promote inside the MCBK community a proactive approach to data quality, because all computable biomedical knowledge representations have been trained or are learning and reasoning on health data in order to be validated, maybe even designed. But then when they're operational, they need to be able to operate in a trustworthy way on the data that they are using on a patient level. And many organizations today in healthcare, example hospitals, are really blissfully unaware of the quality of their data. They fear the worst, of course, if you were to ask them, but they prefer not to look. And we're very keen that they should look. And there are, on the left-hand side, this is a mock dashboard, but there are increasing numbers of real dashboards out there. On the left-hand side are a set of dimensions of data quality. These come from the literature. They're well publicized that you can use. And then you can use various types of graphical display to help, for example, a hospital to understand the systematic errors that are occurring to give rise to poor quality data. Are they human factors? Do you need to have workshops and training and incentives? Are they system issues? Is your EHR system not favoring the capture of structured and coded data in the way I mentioned earlier? Or is your EHR system very easily used in the wrong way because of the way screens are laid out and fields are labeled across clinical teams? They use fields differently. We held a massive 2-day conference almost a year ago in Portugal only on data quality. We think it was the first big multinational conference on data quality to have ever occurred. It was a fantastic event, which I had to personally miss, having helped organize it because of eye surgery, which was a bit disappointing. Well, actually very disappointing, I will confess. We came up with a declaration on data quality, and some of the points on this slide are the headlines from the declaration. We must develop and promote data quality standards and labeling of data sets, which I mentioned is happening in Europe as a forthcoming project, but not globally yet. We must have a way of developing and certifying digital health products, and to have data quality by design as part of how they're built. The assurance of optimizing data quality is not currently inside the certification criteria of most assessment programs around the world. We must therefore require that these labels occur, and we have to invest in people. People really need to know about the importance of data quality, and how organizations and systems can change best to improve the quality of the data they collect and process. And of course, data quality has to be underpinned by a business case, or everybody will say, how nice, but they won't invest in it. So we've got this project I mentioned. I'll just jump on for that. I want to close with a final subtopic, if you like, in perhaps the last few minutes, which is that we've still got to tackle the big challenge of public acceptance. Because when we move from left to right on the slide I've just shown you, there is decreasing public understanding of how and why the data, their own data, is being used. And the actors that are using that data are increasingly unfamiliar. They're not the classical healthcare players, but strange companies you didn't think should be fiddling with your data and analyzing your data. When you use data on the right-hand side of this slide to generate new innovations and results, look at a new drug, for example. It takes years before it hits the market and arises. So people need to understand their data is being used long before they see why their data is being used. And of course, the results of that innovation might not even benefit that patient. They might be sadly too late in their disease to benefit from the information. It may be others. So of course, they find it harder and harder to trust the use of data. So how do we tackle that issue? And that is a challenge. And it's a double challenge in a way, because in our legislative environment, we have instruments that really favor data protection. In a way, the instruments are about locking down the data. The GDPR, the General Data Protection Regulation, is an example from Europe. You could argue, I'm not going to be strong on this point, but I think the HIPAA privacy rule would be the counterpart that you would put from the US side, again as an example, but there is data protection regulation around globally that is trying to help safeguard the individual, which of course we must do. But at the same time, we risk protecting the person's data, but not protecting the person. The person is also protected by having great healthcare. So how do we find that balance? And this is really where we have a lot more work to do on looking at how we protect the public preferences, ensure that the uses of data are always societally acceptable, that we have safeguards, codes, and so on, and that we involve the public. We're transparent with the public about how their data is used and visible societal benefits. So I return again to the European health data space, since that was the topic of my talk. And I told you the EHDS has permitted and prohibited purposes. So I quickly mentioned them before, but I thought I'd put them all on a slide so you can see how are we trying to work towards that balance. So public interests, number one, are there for public and occupational health, supporting public body mandates like regulators who decide if a medicine should be approved or not approved, need access to big data so they can be certain. Then, of course, statistics related to health and care. How can healthcare and care systems optimize themselves? They need to learn from data at scale to discover how they're doing right and wrong. You may remember I started this talk with a slide of orange bars. Orange bars equals this bullet point, I think, in my view. Education and teaching, scientific research relating to health and care, and finally, providing personalized healthcare, which you can often only do if you can look at very large patient numbers. What are you not allowed to do? You're not allowed to harm people or individuals. You can't further the success of illicit drugs and tobacco. You can't do things that contravene public order and morality. You can't use the data to make decisions that adversely affect people. In other words, you can't use the data to single out people you won't insure for health purposes. And insurance is the next bullet down. I've forgotten that. You cannot use the data for advertising or marketing towards health professionals, and you cannot provide data to any third parties. We've run workshops before and after the publication of this regulation and identified additional areas that we would like to see prohibited. And one of those is using the data for learning about any activity that would contravene. In Europe, we have the European Declaration on Human Rights. So that's an example of something. We've also singled out that any research that would fail or has failed ethics committee approval should not be permitted. So I'm just mentioning those as I think the red side is probably going to be a little bit extended if we get our way with it. So I wanted to close really with a penultimate slide that really asks the question. I had it perhaps on the balance scale 2 slides back. How are we going to achieve the right balance between favoring the protection of individuals, which we have to uphold in their data, and yet at the same time enabling the successful, healthy life of those individuals as members of society by learning from their data? And I think here the jury is out about how we can yet still achieve an optimal balance here. We know that if you speak to patients honestly about data and take the time, they're in favor. And so we need to look for the best ways to achieve that, because our ultimate goal is here. Our ultimate goal is to help this cycle to go around, and to go around at a bigger and bigger scale, at a greater and greater speed, so we can learn more and more and really transform healthcare together. Thank you very much for inviting me to speak. I hope this is really, may not be a fact-filled presentation, but I hope it's an exciting one to make people feel that in Europe we are on the brink of something like a real adventure with health data and learning from health data this cycle. And I hope the rest of the world is similarly inspired and echoes the same. Thanks very much.